University of Guelph. And then we have some more colleagues from Sanofi Pasteur Global. And Nassim was a friend of ours who's actually in California. He's an entrepreneur and former founder of Airbnb. So it's an interesting, it's not quite a tech mogul, but not poor. And so actually some of this work was started as some of his frustrations with the Californian government. He's based in LA. And at the time, so that we started thinking about this in April 2020, when both California and Canada and a lot of other countries around the world, we were in lockdown. That was the first big lockdown that we had. So he was very frustrated because he couldn't understand why, tests that were available at UCLA at that point and UC system, this PCR test that we're now well acquainted with, existed, and then the scientists were saying that they can produce them no problem. Why the Californian government would not take them seriously and would not institute a proper frequent testing, so repeated testing to control the virus. Of course, at that time, really was either lockdown, school closures, working from home, or testing and tracing. And of course, his idea was, well, how much testing is it necessary? And we should make a case for it. So this is how we started. And so we actually figured out, well, maybe if we put some math into this question, maybe we can answer it. And so we did. So I'll talk to you a little bit about what we've accomplished. And specifically, we're going to look at 4 countries. They're all first world countries, because at the time when we were doing the work, that was mid 2020, and of course then we revised it and as we went along, and we updated it as per referee requests. Then we ended up looking at the whole 2020. But we kept these 4 countries because in the beginning, the 4 of them had big differences in behavior and specifically in policy implementation. So we thought that was relevant. So we're looking at Italy, Canada, US, and South Korea specifically. And we're looking to quantify the intensity of their COVID-19 measures and how well those went. And then we're going to do 2 estimates of frequent testing and contact tracing. One will be theoretical, one more from numerical simulations. And they're kind of very much agree with each other. And then we're gonna, the last update that we did this work before it actually was published in April of 2021, was to, at the request of the referees, to really look at Canada, but in the context of frequent testing and vaccination, because of course, once 2021 came around, UK and Israel and then US, and then the European countries and Canada and so on, we slowly started having vaccines, and there were vaccination campaigns being implemented in various speeds depending on supply in that region. And I don't know if you're aware, but of course Canada had some supply delays in the beginning of 2021. So our vaccination campaign took a while to get off to speed. So then along the way, parallel to this work, in August of 2020, of course, in Canada during the summer of 2020, we were doing pretty good. We had mask mandates introduced, and of course the weather is nice and most Canadians are outside because we know that in the winter we can't be. So everyone was busy being outside with it, so it was a much sort of more controlled situation on the cases. But of course, as August 2020 came along, then the question for the Ontario government specifically was, oh my God, we have to open the schools in September. The schools means the kids are inside. And what does that mean? right? What does that mean? What sort of policy should we put in place? And through 2020 and currently in 2021, I've been part of the Fields Institute in Toronto, the Fields Institute for Mathematical Sciences. And the Institute had a task modeling COVID task force, they called it. That was put together with a lot of colleagues working on these topics around the province, around Canada. And then there was a two-way communication between the Ontario government and specifically ministries of the Ontario government. They would ask modeling questions to something that is called the Ontario Science Table. And then the Ontario Science Table would trickle down these questions to the Institute and to the researchers at large. And then the Science Table would collage ideas, policies, models, numbers from the researchers and sort of then reporting them to the ministry. So one of the questions in around August 2020 was, what should we do with schools and what sort of policies should we institute in schools so that we keep them open? So some colleagues of mine in New York University and myself, we got into thinking about that because we all had kids at various levels in the system. And so we thought about how frequent should testing and tracing be in schools in order to avoid big outbreaks. And we've done that computation. We presented it up the chain. Although the politicians and the government was aware of our computations, and other colleagues, of course, they did not want to implement it, but they did sort of implement some forms of that they considered less costly. Okay, so this is the overview. So I'm going to tell you what we've actually accomplished. So the introductory part, I believe everybody is well familiar with the virus. We know the R0. So the R0 is the effective reproduction number. So roughly how many susceptibles an infected person may infect on average in a particular population. And the estimates vary. So they're between 2 point something and 3 point something in some regions, depending on when you look all the way in the beginning and how virulent the outbreak was. It could go a bit higher than that. So that's why I put 3+. So just to give you an idea, it's at least twice as infectious, or it was. This is the original strain, right? So it was at least twice, maybe more than that infective than the flu. I know when I say the flu, I say the H1N1. So the tougher, more infectious flu that we were faced with, 5-6 years ago, or 7, I think. So it's quite infectious, and then of course people started estimating the epidemiological parameters for what we're interested in here. We're interested in this incubation period. Oops, sorry. Okay, they're interested in the incubation period, and then the total the time that the patient displays symptoms, for instance, right? So all of these things, the recovery rate, the transmission rate, and so on. You will see all of them in a minute. And at the moment, we sit at around 5 million deaths and many millions infected worldwide. So it's taken a toll in just under 2 years, roughly 2 years. So what we've done in order to address our original question, we wanted to know how to test and trace and how often should we do that. So we needed, of course, a mathematical model to model the infection. And of course, in the realm of epidemiological biomath models for disease transmission, probably the most well-known now to everyone, and definitely very successful for many diseases, are these models of SCIR. So what we did is we fit a disease transmission model to daily case reports for each country to try and have some idea of the effectiveness of these countermeasures in the first half of 2020. we looked at these particular 4 countries for reasons that, they had, for instance, Italy, of course, was one of the most well-known first countries to really be pounded with the infection, right? We all know the story there, and we all know how sort of they slowly kind of ramped up the lockdown measures, and when they finally imposed it, the numbers were so high in the new cases that it sort of made a difference, but the death and the burden of disease was already very, very high. Canada locked down around the same time, but because we are an ocean apart, the number of cases were not by far as high. And also because the way of living right in Canada, we're less densely populated and we live a lot in our cars, so we don't have maybe as much one-on-one interaction. South Korea was a very interesting case. I don't know if you guys remember, all the way in the beginning, they had some cases, and then the entire country got into measures from the get-go, and they suppressed that very successfully. So the reason why they were able to do that is twofold. Number one, South Korea has, like many Asian countries, they have an old tradition of wearing masks. If you ever travel to Japan or to South Korea or anywhere in Asia, South Asia, generally people wear masks, for instance, when it's the flu and cold season. So that's just something that people do, which of course was very welcome in the case of coronavirus. And of course, Asia had to fight much more recently, not just SARS like we had, but also MERS, the Middle Eastern coronavirus strain. And they did that very successfully because they snuff it out. So therefore we in Europe and Western part of the world, we didn't have to contend with that. So they've managed to be very successful at suppressing it. But another thing that they did very successfully from very early on is tracing, isolating suspected individuals and tracing the contacts. And large-scale tracing for South Koreans apparently is not a problem. They have very advanced electronically implemented surveillance systems. The population doesn't just generally seem to mind. Our population seems to mind, about tracing your contacts. Nobody seems to mind putting themselves on Facebook nonstop or Instagram or whatever, right? So different attitudes led to a much more successful public health policy. And we all know in the United States that the unmitigated disaster that went in there. However, both United States and Canada have something in common that these other two countries don't have, and that is that we are a federal system. So we have a federal arm of government, and then we have provinces, or in the United States, they have states, and the local governments they have the freedom and they can decide different things than what, say, the federal arm would like to see. Okay, so what we want to do is we want to find frequencies of testing and contact tracing that theoretically will allow a country to relax some of the stringent social distancing measures, so lockdowns, for instance, but still retaining an R effective of around 1, right? So R effective is the effective reproduction number. So is basically the new number of infected in the susceptible population, but the susceptible population, of course, decreases in time, right, as the pandemic evolves. So that's the difference between R effective and R not. So in general, we have a well-known model, which is the SEIR, susceptible, exposed, infectious, recovered. I'm pretty much convinced that all of the people in the audience know it, whether you like it or not. You've seen it like probably nonstop for the past year. So it comes from physics, it's a compartmental model, right? It was just adapted in the 70s for biological populations, and it was very successful. So we're using the scaled model. So when we scale, we say we have susceptibles over a constant number of individuals in a population in a particular area, and then all of the other variables are scaled. And so what we do is that, well, we say if n is constant, so we disregard deaths and births because the infection is on a much shorter time scale than that. So then what we say is that we're losing susceptibles to infection. So we have an S and an I, they're meeting together. And if they're meeting, then beta is the effective contact rate. So this is generally the contact rate per individual per unit time, say, times the probability of getting infected if a contact happens between an S and an I. Right? So it's a product of two things. We will see it later on. Then in the exposed compartment, right? So exposed and infected, they are both infected. The exposed just don't know it yet. And so in the exposed, we throw the newly infected people, but then it might take some time for them to figure out that they're infected. Sometimes they never figure out just because they're asymptomatic, but if they figure out, and then they go into the essentially symptomatic infected or tested infected. And then while you're infected, you stay there for a few good days, and then at the rate of gamma, you leave the infected and you go to recovered. Note that in this model, we don't differentiate between recovered and death. So recovered could mean both. You live, or unfortunately you pass away, but you're still in this big compartment. So these rates are essentially have relatively easy interpretation. 1 over the rate is days, generally speaking. So 1 over sigma is this called mean latent period, which is generally epidemiologically different than incubation period. So how long you're spending in the exposed compartment. And then 1 over gamma is the mean duration of infectiousness, or so-called gamma is the recovery rate. That's how many days does it take for you to not be infectious. So not to recover. I mean, you might still be quite sick and still at home and do the sniffles and the coughs and so on, but you might not be you're usually not infectious anymore way earlier than you get better physically, right? So that's the gamma that we mean here. Okay, so we also have an auxiliary equation that describes generally the cumulative number of cases. So is the sigma E, so what we throw in the exposed compartment, is the derivative of the cumulative cases. And the daily incidence, then once we integrate this equation, you get the daily incidence is what we are being reported, which is the difference in the cumulative numbers from day to day. In general, we have these two quantities that are very important. This R naught, which is the effective reproduction number, which we get from the original few days of the infection running rampant. And generally in this theoretical model, it's a fixed quantity, and it's beta over gamma. And then the R effective is R naught times whatever susceptibles you have at every T. So R effective is a time series and R naught is a constant, right? Okay, so, but when we are at the beginning of the epidemic or of the pandemic, generally everybody was susceptible. So we have S roughly 1, and we are in what is called a disease-free equilibrium near the beginning. Disease-free is just before there was no infection and it just started. So in that case, we can see immediately that we can integrate, if we're looking at I of T, just the new number of infected. That is going to be some exponential function with some power rho, which we call the growth factor of the infected, right? So it's some form of exponential function, and so is the incidence. Okay. This is going to be important. So this rho here is called the growth factor. And again, in an SIR model, SIR means we essentially take out the exposed. We consider that there's no exposed period, you go directly from S to I. That's the simplest version of these models. So if you are in that version, then we can estimate this growth factor for the infected to be exactly recovery period gamma times R naught minus 1. So it's very epidemiologically kind of driven, right? And directly depends on how horrible R naught is going to be. And then we can obviously derive an expression of R naught just based on this growth factor, which is very good because the growth factor, we can, as you will see that we're going to estimate it from current data. Okay, so we have an expression of R naught for SIR. If I have an exposed compartment, I can derive a not too hard closed form mathematical expression for the growth rate in the SEIR, which involves now all of the rates in the model I showed you. And of course, then we can solve for beta, and then given the link between beta and R naught, we can solve a closed form solution for R naught based on the growth factor of your original infectious disease. So to depict control measures, we wanted to add one more compartment. We can add way more, but our point was to use a not too complicated model, commonsensical, but still squeeze something important out of it. So we added an L compartment. L stands for isolated, right? So we wanted to have a way in which we implement contact tracing and testing. And usually the contact tracing and testing happens, of course, both in S and E. I mean, you could be exposed. You have no idea that you were exposed, right? And somebody could contact trace you as a possible contact of somebody else. Or let's say if you have a proper testing policy, you show yourself up at a testing site and say, well, I want to see what my status is. So from these guys, we throw into the new compartment, which is the isolated, we throw these guys at two different rates. If you are infected, so you know you're proven that you have coronavirus, generally you get isolated by, you're sick, you stay home, or you go to the hospital, or so on. If you're just exposed and you might not have symptoms yet, but you are proven to be positive by testing, you're also told to isolate. Right. So these are the two numbers that we're interested in estimating. This is just a quick sort of reminder of these sigma and gamma would be. And so these are standard things. And now in the new incarnation of the model with now another L compartment, we can redo some of the existing closed form formula math. And we have a growth factor for this particular model. And based on that and all the other parameters, including testing and tracing, we get a new closed form expression for R naught. Okay, so that's very good. So these guys, sigma, gamma, and gamma are model-based, epidemiologically based. Rho could be from data, and kappa 1 are the ones that we can play with to see how, if at all, we can control R naught, right? Okay. So just a quick inference here. This is very simple computation as us trying to figure out how long should we get this latent period and infectiousness period. So the latent is how long roughly you sit as an exposed individual. So it's roughly about 2.5 days, 2 to 3 now. It's more like 3 in the latest. This is, of course, was middle of 2020. So some of these values may have been epidemiologically updated. And the infectiousness is, how many more days are you gonna be still infectious after you show symptoms? And we picked 2.5 days. And if we're just looking at this formula that we had here, this guy, number 7, we just played around and plugged in values for the parameters. What we get in terms of, kappa and kappa 1. So we did get these two surfaces. Kappa is measured here, and we figured is between 0 and 1, right? Because 1 over kappa is number of days that you spend until you're told the result of your test, or number of days until somebody told you, hey, you're infected, go and stay home, right? Or until you see there's something is wrong with you. So so the K's are here, the K1 is here. So if we plug this in on a grid with various sigma and gamma values, the latent and infectiousness period. So if they're both 2.5 days, we get the uppermost surface, this one. If they are longer, so you spend longer in the exposed, but you also spend longer being infectious, even after symptoms, then you're somewhere in the darker lower side. The flat one is R effective, R0 being 1. In other words, as you know, we want to be under. So you can see that there are regimes of kappa and kappa 1, right across at the intersection. There are regimes for which, so intervals for kappa and kappa 1, for which these two curves, which are the R effective, are clearly under 1. Okay, so testing and tracing is achievable. There's values that we can achieve in such a way that we can control this R naught, which means we really control R effective. So how did we go about to, let me check the time. Okay, so I have how much time? I have an hour or?
Michael, yeah, 1 hour, I think. Yes.
Okay, I will try to
roughly.
I will try to be a bit less than an hour so people can ask questions. Okay, so the next two slides are not too complicated in terms of what we've done. Is we basically took our model and we wanted to fit it to the first exercise, to fit it to reported data for the 4 countries in question. So, and then we plotted to see how well we fit it to data. And so in order to do that, we needed to figure out how to evaluate rho, this exponential growth factor, right, from the beginning of the epidemic. And of course, like everybody else, we used data from the Johns Hopkins website. So we used something very interesting and very simple. Remember how we used to say that the incidence, so what we get reported every day, is to some degree is the difference of the cumulative cases, but the cumulative cases, when we integrate, are really a function of this growth. So it's an exponential function with the exponent being this rho, which is the growth rate. In other words, if I take the log of the incidence, I should find, at least in the beginning of the pandemic, I should find that the log of the incidence is really a log linear plot, right, with the slope rho. So I can try to determine rho by doing that. So if we do that, we indeed are successful. So for instance, for South Korea, the blue regime represents our estimate from data. And when it changes, you can see that we change from the exponential growth regime, which is the infection just in the beginning, not being controlled by anything, to the red side where measures are being implemented, right? So the exponential growth for South Korea, it's somewhere with some confidence interval, of course, it's somewhere around 0.22, and R naught came down to be, in their case, just estimated from data, somewhere about 2.3 for South Korea. For Italy, we did the same thing. These vertical, by the way, these vertical lines are the actual dates in 2020 when the first lockdown measures were declared, if there were any, when the lockdown measures were implemented. So you can see mid-March here for Italy. Italy was quite going up. It was an R of 2.2 roughly, and a rho of 0.18. And then, of course, they took measures and then they went down. Canada, a similar picture, about 2.11 and then 0.18 with some confidence intervals here. Again, we also locked down mid-March. And the US they also locked down around for, second week of March. For them, the R naught turns out to be 3, and the rho is 0.3. So quite more virulent situation. So this is our table. And what we're interested in, so these are the countermeasures, the sub-exponential onset. This means these red periods, right? So after measures were introduced, you can see a bit of a delay in all cases, and then you can see the effect of the measures sort of taking place, right? Everywhere it's the same sort of picture. And here I'm going to talk quickly about it, is this idea of the underreporting factor, because of course, in the beginning of the pandemic, depending on the country you were in the world, people were just, generally cases were just underreported because, the medical professionals, everyone had to catch up to figure out how to recognize the symptoms of COVID, what were the symptoms of COVID as opposed to symptoms of influenza-like illness or any other respiratory diseases. So it was a lot of confusion, a lot of things that were being missed, right? Okay. So then for each country, we fitted our simulated model now with rho in place and all the other epidemiologically estimated parameters. We fit it to the daily incidence. And so what we did was we looked to figure out which one is the best fit. So we looked at the minus log L, so the normal negative log likelihood, in the 2 time series, one that are the incidents observed, and then one that is obtained from the model. And then we estimated R naught as before I showed you in the plots. And then we produced new plots to see how well we did. And of course, we did uniform Latin hypercube sampling to estimate other parameters so that we fit. And here are the best fit plots. This is South Korea. And you can see that actually these plots are to July of the end of July of 2020. So we have more recent, if you're curious in the paper, you can find it online now, it's all published. We have it a much longer, we have more plots, and we can show all the way to, I think, the end of 2020, so the other part of the year. This is South Korea in terms of the cumulative numbers. And here we have this plot, which is called our own estimate of the beta reduction. So how successful were they in reducing beta? Remember, beta is the effective transmission rate. So the one that multiplies S and I. So that's the one that we really want to reduce, right? Here it's just deduced from numerical simulation. So they've done pretty good in the first part of South Korea, first part of 2020. This is Italy, a big spike. And then you can see that the measures managed to bring things down roughly under control by the sort of towards the end of the summer. You can see the beta reduction. Again, they had very stringent measures and they worked and they stayed like that. This is Canada. Right, we didn't have as a spectacular growth, but we did have something. And then again, our effectiveness of beta is pretty good, right? Generally, Canadians are a bit more compliant with regulations than maybe populations of other countries. And then the US, of course, they went down for a bit and then up. And then, of course, as you know, they were already shooting way back up into the second wave, even before the summer was over. So the US is a clear example where the measures had some effect, but because people didn't respect them and they were all heterogeneous, they didn't really have as much of an effect as desired. So while they have them, they worked. The problem with, of course, the US is you can see here the vertical scale, right? These are the number of cases. The US was at 30 something thousand a day before they even got into measures, whereas say in Canada, we were at 1,500 or, under 2,000. So numbers are important here because of course we're talking about exponential growth regimes. And the worse you are on your newly infected curve, the higher you go in that exponential regime, the harder it is to control, to bring it down. Right. So keep that in mind. Okay. So now testing and tracing rates, we want to estimate them theoretically. So we're going to extract the current value. So we did this at the middle, so the end of July of 2020. So we roughly estimating how much of susceptibles were in the 4 countries. We also estimate a current or effective, depending on where they were in July, at the end of July in that country. And here's what we got. So we got the S was clearly quite high, right? And South Korea was almost 1. I mean, South Korea had very, very few cases compared to all the other countries. So we didn't bother with it. We just left it at 1. Italy was at 0.9394, Canada a bit higher, US a bit higher. So the betas that we deduced from the numerical simulations and the formulas we had are these here for the beginning of the pandemic. So this is unmitigated beta. And the R effectives at the end of July are around here. So as you can see in the US, they were still climbing nicely. South Korea was kind of hovering around 1, and Italy and Canada were in a period of remission. So we were still going down. And so what we did is we implemented Kappa and Kappa 1. So we made them the same. We said, okay, let's say that is the same number of days for somebody to get the response of the test, or for somebody to be told to be contact traced. And so how frequently should we do this? And it turns out that in South Korea, if they were testing or contact tracing an infected case every 4.5 days out of the population, then they would have been okay to control to further control their pandemic. For Italy and Canada is very similar. For the US, of course, we don't want to control, we don't want R effective to be 1.2. So this was not a good result. So then what we did was, well, okay, let's take the same values as before. Let's assume that we want to keep everyone at 1. So we're not even aiming to be too ambitious. We just keep things afloat. So then for South Korea would have a 4.5 days frequency of testing and tracing. Italy would be a 6.2, Canada 5.7, and US much more frequent, about 3.5 days. Now, this is an average over the country's population. It doesn't mean that you have to test everyone in the US every 4 days. So the policy would be differentiated over, who you are. If you are let's say, essential worker or in a risky environment, then yes, you want to be tested frequently. If you are a white collar job tech person or banking person who was at home for most of 2020, you didn't need to be tested every 3.5 days. Perhaps you need to be tested, I don't know, every 2 weeks or so, right? So this is something that we want to keep in mind in terms of possible policy. So these plots are to show you that even in the simulated numerical simulations, they tend to very much backtrack what we are saying here. In the simulated scenarios, we played around with all sorts of values of testing, so without even contact tracing for a while, just massively testing. And then if we test and contact trace, and you can see that between 4 and 5 days, this is South Korea, right? Mid of July, they would have mitigated their stuff instead of going all over the place. Testing alone, these more colored curves is not enough. You need contact tracing to control. This is Italy, again, that would have been fine for them. Canada, relatively okay, even 4 or 5 days, we would have done fine. The US, even for the US, you can see if we test and trace 4 days, it's not ideal, but you know, if you come down to 3 point something, then their second wave, which was well underway at the end of summer 2020, would have come down faster. So now if we have, because we were asked in 2021 to update our model a little bit to consider at least a vaccination scenario, we looked at December 21st to April 30th, 2021 in Canada. We started the vaccination campaign late, very late in December, so really January. And by end of April 2021, we had around 12 million people vaccinated in the entire country. Not a lot, we are 36 million, okay? And so we had about 12 million people in 130 days. And we consider here an efficacy of a vaccine about 70%. The reason for that is at that time, we had a mix of Pfizer, Moderna, and AstraZeneca, and mix of all ages, and those were all less effective. So this is like a blended overall effectiveness. So what we did is we considered one more compartment, which is a vaccinated guy compartment. And of course, we vaccinate out of susceptibles. We don't test them before usually, so people show up. And we have vaccination rate of row of T. I understand an actual paper, I think we have Delta, so I apologize for that. We already had row before. So this is the vaccination rate, which is time dependent, the efficacy of the vaccine, and then we have this new compartment which gets populated with people who get vaccinated. Sorry, I went backwards. I apologize. Okay. And so with this new model, then we had a couple of more things to add, because in Canada, we had, of course, like anybody else, we had the original version of coronavirus with beta, and we had this beta variant of concern. And at the time was alpha. Alpha was starting to be more and more present to take over. And we, because of that alpha and because our government, at least in the big provinces in Ontario, didn't really take it seriously, we found ourselves in a giant lockdown at the end of March and all the way to basically June of this year. So because of high numbers. So we did a blended transmissibility rate. We started with beta for a little bit until January, mid-January, and then we started to average weighted with the VOC, right, to mimic the ascendance of the various variant of concern in the population. And we had some Public Health of Canada data to do that. And then, of course, we wanted to mimic the actual vaccination that took place in this time. And we wanted to start from 0 and to get somewhere around 12 million people. And so we kind of piecewise our way through a possible estimate of a vaccination uptake, which is this row. And then with this, so this is what we get, the cumulative vaccinated, which is very much resembles what we had at that time. This is the interesting plot. So this is the plot where the green wiggly curve is the actual number of cases. You can see in January, we were like, not doing so great. We came down until about February. And then the government said, we're great. We're going to open up our economy because economy. And of course, immediately they opened, and by mid-March, we were back up, and then worse. We were actually quite higher up for a bit. Now, these curves here are the purple one is vaccination with just vaccination campaign, as it were, but no NPI measures. So we took off no effect from any NPIs. Not great. Then if we do testing and tracing, note how much less often this needs to be. Say if we did it every 2 weeks on average for every individual, we would have been on the blue curve, and you can see right away that we would have done much better, and there was no more wave coming up. So to quantify that is total simulated cases with proper testing and tracing and vaccination, current cases to end of April, and here's the case reduction. So huge, right? So testing, repeated testing and tracing is could be as effective as, probably more effective than lockdowns. So then again, this is my last 2-3 minutes. When we did this computation for Ontario's elementary and secondary schools, because that's what the government was really concerned about last summer, we wanted to again control R effective, right, to be 1 or under. We took a very similar model that we had here, except we made it for 2 subpopulations. We had students, the population 1, and teachers, because this is a teachers and staff. This is the population of a school. And we only ran the simulation for school days. So we kind of disregarded the time being spent at home because there were still measures in place. Sports were not allowed, concerts were not allowed, cinemas were not allowed. So basically the kids would be mostly home. We had some estimates for contact rates, person to person. These were in the literature, and some estimates for the probability of transmission per contact. That was from the current literature. And again, you see the 2 kappas, isolation and testing. This is what Maple spits at us in closed form solution if we want to know what our effective is for these guys. Of course, we cannot work with it, right? But it exists. It gives us numbers. But what we ended up doing with it was to conclude that, in fact, testing and tracing frequency is not so important in the teachers. Doesn't really make much of a difference in the population of teachers. Teachers generally now, and even now in schools, are restricted in movement. They generally stay with their class. We had this idea of cohorting, where classes had to hang out with the same people in the class, not in between. So that was not so important. The students, of course, were the ones carrying the load for infection, which is still happening even now. And then if we're leaving alone the teachers and staff and just concentrate on students, we got as a policy that, for instance, if you test 3 students out of every class daily, then you would amount to basically keeping R effective less than 1. And that's not a lot of tests for a month. And yes, Ontario has 4,000 schools, but we were absolutely very much under capacity at that time when the government was asking if they have capacity to do it. The answer was yes, they had it. If we added mask wearing and other social distancing policies that the government already was implementing, we were told, and they did implement them, then these reductions were significant. And in fact, you could reduce the policy to basically just testing 1 student in every class per day. So roughly a student would be tested maybe once a month. And then you could just keep things under control, and you note the number of tests is much lower. So definitely lots of room to do this. They did not. But they did something called a blitz vaccination campaign. So they would go to certain schools over the weekend in areas where there are more cases, so regionally, and they would do a blitz vaccination of that school. Quebec did that as well in January and February. And now, only now in Ontario, the government said that some schools, not all, but a lot of them, will have access to rapid antigen testing, which you would have need to do this just now, just until, I guess, the vaccine for 5 to 11 is going to be approved, and then the kids can get vaccinated. So late, but better later than never. And then there's some conclusions. I don't know that we need to waste too much time with them. I think I've convinced you that this would have been and could still be for any other things like this that might show up for us in the future. Testing, repeated testing is very important. It's hard to ramp up, of course. It took us a few months to ramp it up in at least in this part of the world, but it would have been a good investment, especially if you look at what it cost us in terms of economic downturn, and how much money the governments had to pump in economies to keep them afloat, versus how much it would have cost them to repeatedly test us and let us work more. I have some friends in economics, and they're pretty certain that it would have been beneficial, even from a cost analysis. So yeah, relaxing social distancing measures can be done, although, you know, if you do it willy-nilly, as US shows, and right now, most recently, Canada, specifically Alberta, where it was a complete craziness for the past 2 months, because in July, Alberta declared unilaterally in the world that the pandemic is over, and they just didn't want any measures anymore. And then by the beginning of October, they were running patients to Ontario and Quebec because they didn't have room anymore. So that's how bad they are. They're a bit better now. So that was a direct, most recent illustrations, unfortunately, of relaxing social distancing, specifically masks. The relaxing mask indoors is a very bad idea. Not you guys live it in UK. Israel lives it. The US lives it as well, and some parts of Europe. So there's some estimates here. There's test kits, of course, available nowadays. So all this is very implementable. It costs, of course, and we have some drawbacks in our model, because we did it, you know, country scale, but you can do it for smaller populations, and I think it's equally could be equally good, and a lot of references, of course. And I think I'm going to stop here. I'm going to leave some room for some questions. Thank you.